All right, party people. Thanks for joining us this Tuesday evening. My name is Amy Pearlman. I'm a urologist. I direct our men's health program at the University of Iowa Hospitals and Clinics. And I've been here for almost 4 years. And I have my sidekick, guru, patient advocate, patient rock star, Dennis Wallace here. Dennis, say hello to the crew.
Good evening, everybody. Glad you could all make it. And let's have some fun tonight.
Awesome. All right, we'll kick it off with some disclosures. I am a consultant for and receive grant funding from Boston Scientific and Endo Pharmaceuticals. We're going to go through a lot of information tonight. My sister always tells me I speak a little too quickly on these webinars, so I'm going to try to slow it down. But we will be talking for the next 45 minutes or so. We'll leave some time at the end for some Q&A. We'll keep an eye on the chat box throughout. If there are questions that you have during the session, please bring them up in real time and we'll address them during the webinar. There were so many of you who asked really great, thoughtful questions ahead of time. And I actually went back through my PowerPoint to add some of that detailed information in. So if you asked a question, a lot of that is actually going to be addressed in the PowerPoint slides themselves. But today, you and me and Dennis, we're just talking tonight. You don't have to remember this information. We'll be posting this webinar, the recording online afterwards. You'll get it in a link. And so feel free to watch this webinar however many times you can, because you'll probably pick some new things up each time you watch it. We're going to go through some basic things when it comes to testosterone deficiency. It's one of the topics that I enjoy talking about most. And part of the reason is because a lot of people are interested in this topic. It is a hot topic. And Dennis really enjoys talking about this topic as well. So we'll start off with some basic anatomy of hormone signaling, because in order to understand the different evaluation and treatment options, we first have to understand the basics of where the signals come from. And then we'll delve into signs and symptoms of testosterone deficiency, talk about the evaluation, management options, and then risks and benefits of testosterone therapy. Basic anatomy. When we think about urology, oftentimes we think of the bladder and the urine and the prostate, but really when it comes to what urology and testosterone and hormones are all about, it starts way higher than the kidneys and even the adrenal glands. And it starts with the brain, with some brain signaling. So the signal starts in the hypothalamus, which is a structure in the brain. The hypothalamus secretes gonadotropin releasing hormone, or GnRH. And that then goes to the anterior pituitary gland, another structure in the brain, which then secretes several molecules, but the ones relevant for this talk are going to be LH, or luteinizing hormone, and FSH, follicle stimulating hormone. LH then goes to the testicles, and there are cells, the Leydig cells in the testicles, that then produce testosterone. Testosterone, when the body sees enough testosterone, it actually sends negative signals, negative feedback all the way back up to the brain to say, hey, brain, we have enough. Now, FSH is less important when we're just focusing on low testosterone, but the testosterone conversation, you really can't know the best way to treat someone unless you also understand someone's interest in current or future fertility. So FSH really comes into play when we're working someone up for male infertility or we're worried about future fertility. So all this downstream signaling. Now, when it comes to why so many guys will come in to see someone like me, it's because the signs and symptoms of low testosterone are so common in men in general. The androgen deficiency in the aging male questionnaire, the ADAM questionnaire, is one such questionnaire that might be used to try to bring guys into the office to engage men to say, hey, you might have low testosterone, come on in. Now, based on our national guidelines, the American Urological Association guidelines, there aren't any questionnaires that have been found, useful or that are recommended for whether or not to assess someone for low testosterone or how to track whether or not testosterone is helpful. But I do find these questionnaires helpful, especially for settings like this, for people to understand, like in my day-to-day life, what does it mean to have potential symptoms of low testosterone? decrease in libido or sex drive, lack of energy, decrease in strength or endurance, have you lost height, decrease enjoyment of life, sad, grumpy, erections less strong. You can read some of the rest here, deterioration in work performance. So when I go through this, I mean, for me, minus the less strong erections, a lot of us are going to say, check, 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 check. So it is, low testosterone concerns are, concerns of so many people. Based on our American Urological Association guidelines, this table does a great job of summarizing the common signs and symptoms associated with low testosterone. So reduced energy, endurance, work performance, physical performance, loss of body hair, reduced beard growth. Some guys will come in to say, look, I asked my primary care provider to have my testosterone checked, and they said, well, there's no way you have a beard, you have muscles, there's no way you could have low testosterone. But even men with big muscles and beards can have low testosterone. Other signs and symptoms include fatigue, reduced lean muscle mass, obesity, and different cognitive symptoms. Some people describe these kind of all together as I experience a brain fog. My memory isn't quite as good as it used to be, and I'm not sure how to sort of get out of this. And I want to be more productive with my work and when I get home from work, but I'm struggling. Things like irritability and poor concentration. And then sexual symptoms and signs like reduced sex drive and reduced erectile function. But as you can see from this list, the implications of having low testosterone go so much further than what a lot of people think is, I want bigger muscles and I want my erections to be awesome and to have sex drive that's through the roof. So testosterone has implications on all parts of the body. But it is like opening up Pandora's box. I think, it's probably one of the reasons, just guessing here, why a lot of you are on this call tonight is you've probably had concerns about having low testosterone, and people have mixed interactions and experiences when it comes to interacting with the healthcare system. I'll let you in on a little inside scoop here is in medical training, there's no mandatory men's health training. There is no mandatory men's health training. So whether, for medical students, for example, we have mandatory women's health rotations, and physician assistant students have mandatory women's health rotations. A lot of students will have the opportunity to decide whether or not they want a urology experience, but it's rare that that's actually mandatory. And even within, if someone rotates through urology, most urologists don't treat low testosterone. Okay. So most of the providers, I'm trying to give you some sort of context about why people may have had different experiences when interacting with the healthcare system. It's oftentimes because most providers have never been taught how to do it. And when there's a disease process or a concern or a question that we haven't been trained how to do, it can make us a little bit nervous, and we try to shy away from it. So that, is a big reason why you may not have had your questions answered. The other thing too, is it's a taboo topic. Even though a lot of people want to talk about it, people have this misconception that anyone who's concerned about low testosterone wants to abuse it and use it for performance enhancing. And that is so far from the truth. I mean, that's definitely interest for a lot of people, but that's not actually what we're talking about here. We're talking about guys who come in with signs and symptoms and low testosterone levels who want to feel better, improve the quality of their life. But we can't really talk about that without acknowledging anabolic androgenic steroids, which is why part of this topic is so taboo. So these are synthetic modifications of testosterone. They're made specifically for athletes. They're undetectable, and they're not approved for medical use. And most will use the intramuscular injection form, but in way high doses than we would ever consider using in standard clinical practice. So people might use an equivalent of 1,000 milligrams of testosterone per week. I wouldn't use more than 200 milligrams per week. So some of these folks will take 10 times the replacement dose. Now, the medications that I might prescribe in my office, whether it's testosterone or some of the other medications that we'll delve into, a lot of them are actually similar medications that bodybuilders will use. Bodybuilders will oftentimes use these other medications to counteract all of the estrogenic side effects that will come from raising the testosterone level so high. Testosterone, some of it can get converted to estrogen. So when guys are taking really high doses of testosterone, that'll raise their estrogen levels, and that can cause actually a lot of the bothersome side effects like acne and mood changes and fluid retention. So even though the medications are somewhat similar, the dosing varies widely. To get into the evaluation, it's simple and it's complex. So to simplify it, we do like to check early morning total testosterone levels. And the reason why we check early morning levels, or whenever your morning is, so if you work night shift, then your morning technically may be a little different. So we want to check it whenever your morning is. And the reason is because there's a pattern where testosterone will peak in the early morning hours and then go down later in the afternoon. And those highs and lows are going to be more drastic in younger men, those less than 40. So not saying those older than 40 year olds, but in older men, you have more stable ups and lows of the testosterone levels. So we check it in the morning because if we check it in the afternoon, we expect it's going to be lower. And so we don't always know what to do with that information. And some insurance companies are pretty picky on the time of day of that lab draw. Testosterone levels can vary day by day. So we do need to repeat the early morning testosterone level on a different day as well. And then the question becomes, well, why does this person have low testosterone? Now, we can't pinpoint an exact reason like, oh, it's because of obesity, it's because of diabetes, it's because of this surgery or that radiation. But we try to pinpoint to get a little bit more detail of where the signaling might be awry. And that's why we check some of these other serum or blood test levels. If that second total testosterone is also low, and our national guidelines use 300 as a somewhat arbitrary cutoff, especially for insurance purposes and for research, there's got to be some cutoff that we've agreed upon when we define low testosterone. So 300 is what it is. If that second one is low, then we're going to check upward signaling. So we check the pituitary gland. And remember that main hormone that we're looking at there, or molecule, is going to be LH, because LH is going to signal the testicles to produce testosterone. So if the LH is high, that means the body, the brain is seeing the low testosterone and saying, hey, brain, we got to ramp up production. Let's go. And so the pituitary is actually responding appropriately to the testicles not producing enough testosterone. Okay. So that would be a testicular problem. The brain is trying to signal the testicles aren't doing it. That could be from radiation, let's say, chemotherapy involving the genital parts, or a genetic disease. Okay. If the LH is low or low normal, within the normal range, it means the pituitary is not really seeing that low testosterone. So that's actually, even though it's maybe normal, it's an inappropriate response to having low testosterone. Okay. This is what I mostly see in the office. My practice is not focused solely on male infertility. So most of what I see would be considered secondary hypogonadism, where it's a brain signaling issue. And the brain signaling thing can be due to a lot of different comorbid conditions, including obesity and sleep, and several other causes that we'll delve into in a few slides. We'll check FSH if someone is interested in current or future fertility. I check estradiol at baseline because I want to know, is the ratio off between testosterone and estrogen, especially guys coming in who have breast symptoms, and that's mainly their concern, like breast tenderness or breast swelling. Their testosterone may be low or low normal, usually low normal, but if their estrogen level is on the higher side, sometimes I'll just treat that elevated estrogen and their breast symptoms will get better. But I am a big proponent of checking estrogen. Whenever I see side effects in my male patients, usually it's a problem with the estrogen level and not necessarily the testosterone level itself. So I check estrogen pretty often. Hemoglobin A1C is important for those who are at risk for diabetes. A lot of the guys who come in to see me in clinic may not follow regularly with a healthcare provider. And so in many cases, I'm putting my primary care provider hat on to say, okay, well, we finally got this guy into the office. We opened this door for him. He wants to talk about testosterone. So while he's here, what else might I be able to do that I feel comfortable with to make sure I'm not missing something else that could be contributing to his symptoms? And then depending on the LH, if it's low or low normal, then we're going to check another pituitary hormone called prolactin. If prolactin is elevated, and that could be, it could be like a small tumor in the pituitary gland, not cancerous. This is a non-cancerous lesion, but it can be like a mass in the pituitary that can raise prolactin levels, which can then lead to low testosterone levels. So that's where we'll check the prolactin level. And then if the prolactin level is really high, we'll get a brain MRI to see if there's any pituitary mass that either needs some medication to help shrink it, or sometimes even surgery to remove it. But we're not talking about cancerous lesions here for the most part. In terms of the definition for testosterone deficiency, and I use the word testosterone deficiency because that's where a lot of our guidelines and verbiage is moving towards, but it's the same thing as when we talk about really hypogonadism or low testosterone. Our national guidelines use 2 morning total testosterone levels less than 300, in addition to symptoms and or signs. So symptoms and or signs with a well within the normal range testosterone level would not be would not be defined as low testosterone. And same thing, there are some guys who have, levels of, let's say, the high 200s, but they feel great, who may not be interested in starting testosterone, and that's totally fine as well. There are limitations of this definition, though. And one big limitation is that there are no age-based references. And there were several people who actually asked questions specific to, I'm like 75 years old, what's a normal testosterone level? And that's where a lot of this gets lost in different clinics, because we use that 300 cutoff, or certain providers may look at the reference range of whichever lab facility you went to get this checked. And when your, let's say, primary care provider orders a whole bunch of labs, oftentimes we're looking for the L's and we're looking for the H's. What's high, what's low, what do we need to intervene on? And so even if your level is, let's say, high 200s or high 100s, if that's technically within the normal reference range of that lab, that provider may say, hey, everything looks good, everything looks normal, because there wasn't anything that was flagged. So it's really important to look at those numbers as well, and not just what flags as high or low. But the reference ranges vary. Some labs will say 191 to 700 is normal. Some will say 241 to 800 is normal. So it really depends as well. And it makes it difficult for both patients and providers to really understand these lab results. And then the other thing that we have to acknowledge is that total testosterone is not the end all be all. Total testosterone gives us some idea of the hormones in a man's body, but it's more complicated than just looking at the total testosterone. And the total testosterone number actually comprises a few different things. It includes testosterone that is tightly bound to a molecule called SHBG. Testosterone is also bound to a protein called albumin, but it's not as tightly bound. So actually the link between testosterone and albumin is much weaker than the link between testosterone and SHBG. Now that's important because the testosterone that's bound to SHBG is not going to be active in the body, all right? Whereas the testosterone that's attached to albumin can act on the cells in your body. And then we have free testosterone. So that's just testosterone floating around by itself. So when we consider the testosterone that's in someone's body that can actually be active to do its part, it's going to be combining the free testosterone, which is just a minority of that total testosterone, about 1 to 3%, and the testosterone that's bound to albumin. And that's what we consider to be the bioavailable testosterone. But our national guidelines emphasize total testosterone in the definition. There are a variety of things that can impact someone's SHBG level. And so sometimes we'll check someone's free testosterone. We'll check to see what their SHBG is, because if their total testosterone is well within the normal range, but that person's SHBG is really high, then that could be a reason why they feel the signs and symptoms of low testosterone, because it's not biologically active in that person's body. When it comes to the prevalence, I mean, look at that range, 2 to 50%. And that's because the definitions are widely variable. Depending on the research study, they're going to be using different cutoffs for low testosterone and different thresholds. And different assays, different ways of testing it. So that's why when you see that prevalence of 2 to 50%, I mean, we don't really know what to see there. But I know in my own clinical practice, that low testosterone signs and symptoms and actual low levels is quite common. Something else to consider is what's expected to happen with testosterone as a man gets older. And testosterone levels decline actually starting at 30 years old and are expected to decline about 1% per year. I like this graph a lot because it shows, again, what happens with these different components of testosterone as men get older. You can see from the red total testosterone line that this is going to steadily decline with age, as does free testosterone, and that molecule, that darn SHBG that interacts with a very strong connection with testosterone goes up. So this is a very important graph to consider. All right, let's go into some causes here. And I'm not going to read through all of these because there are so many different causes of why someone can have a hormone issue. I did highlight some major ones here that really tie into some of the questions that people asked. So because the testicles are going to be the primary organ that produces testosterone, any injury, radiation, chemotherapy that affects the testicles can cause low testosterone levels. For people who, let's say, had surgery as a child, as a baby, for, let's say, a retractile testicle or an undescended testicle, it's always possible, depending on when that was fixed, that could later on cause issues with low testosterone levels. Testicular infection can also affect the production of testosterone. Acute or chronic illness can also affect hormones. And this is of people, of really any gender. If you're sick, you have a febrile illness, that can absolutely affect testosterone levels. If you had COVID or have COVID, that can absolutely affect testosterone levels as well. Obesity is a big one too. Obesity, for several different reasons, will affect how testosterone works in the body and the signaling for testosterone production. Sleep apnea, diabetes, all of these different things. And most of the time when guys come in, it's not one single thing that's causing their low levels. It's probably 5 or 10 that we can name, and probably another 5 or 10 that we didn't know to ask. Maybe our patient didn't know to bring up. And so we just haven't identified those. There was a great question asking if the COVID vaccine caused low testosterone levels. And there's been limited data with not very long follow-up, but as of yet, there's no evidence to suggest that there's any negative impact of COVID vaccines on fertility or sexual health. And what we know in terms of having a COVID infection is anything that makes someone sick can impact sexual health, can impact testosterone levels. So it's important just to overall keep yourself healthy, and any illness can impact hormones. This chart here goes through this very complex way by which things like obesity and testosterone and insulin resistance interact. And a lot of it is based on pro-inflammatory markers that are released and effect on estrogen levels and triglycerides. And so the more adipose tissue or fat cells someone has in the body, it's going to increase inflammatory markers, insulin resistance, and all of these things are going to have an impact on testosterone. So we'll get into some of the lifestyle modifications to boost your own body's ability to produce testosterone. But in general, diabetes, obesity will contribute to low testosterone levels. And more research is coming out now to say that when you treat low testosterone levels, it actually can improve insulin resistance and obesity. I always like to direct people to our national guidelines, because if we expect both patients and providers to be on the same page, we have to be looking at the same information. That's where a lot of the conversations oftentimes go astray, is when the patient's looking at one resource, the provider's looking at another. And so you're clearly on 2 different pages and 2 different conversations. And I like to look at the same information, so you know why I'm bringing up certain information as I'm looking at the guidelines. And also, a lot of these guidelines, you don't have to delve into the details and the manuscripts, but if there's summary statements at the beginning of these guidelines that can be really helpful. And if anything, it gives you some baseline information that you can bring to your healthcare provider to at least start the conversation and ask some good, thoughtful questions. So if you go to Google and you go AUA guidelines, testosterone deficiency, you can pull up our AUA guidelines, and everyone and anyone has access to these. First line therapy when it comes to pretty much anything in medicine is going to be lifestyle changes. Now, it can sometimes be difficult to talk about this, especially if you're seeing a provider in a very busy, surgical clinic. Is sometimes we skip over these things. But at the very basic level of health and wellness is what we eat and how we move our body. And I would not be doing my job unless I acknowledge the importance of things that each and every one of you on this call can do for yourselves. The biggest role, the biggest takeaway that Dennis and I have for you tonight is you all have incredible control over your health. So if there is any way that we can, empower people to take control over their health and maybe not need medications or surgery, then everyone is winning. So let's talk about some of the lifestyle changes that can be incredibly helpful to boost your own body's ability to produce testosterone, as well as help improve some of the signs and symptoms you may have that are concerning you for having low testosterone levels. Weight loss and or maintaining weight within a recommended range is going to be helpful. And it goes back to that slide, looking at the inflammatory markers, obesity, and insulin resistance. Increasing physical activity is good for every part of the body, including hormones. It is okay to eat soy products. So that is perfectly fine. It doesn't increase estrogen levels, and good sleep is important. So maintaining our circadian rhythms and our REM sleep, it's all about that brain signaling, and our brains need to be healthy to give good signaling. All right, let's talk about supplements. Also, several questions that were asked about supplements. And part of the thing about supplements is, as healthcare providers, it's not a big part of our training. So a lot of the questions that people ask are going to be about things that healthcare providers were actually never taught about, because if it's not FDA approved, it oftentimes doesn't show up in our curriculum. But we have to address the common questions of everyday people in order to make sure that we're keeping our patients safe. So when I think about supplements, I think about a kid in a candy store, right? You go to like CVS or Walgreens, you walk down the aisle of all the different supplements and you're like, ooh, that looks good. Like, I want to have big muscles like that person. Or you're, let's say, watching a commercial in the morning when you're at the gym, you see a guy at the gym and all these women are around him and you're like, ooh, Nugenics, I'll take some of that. And so when it comes to supplements, there can be some helpful supplements. Vitamin D is going to be important for optimizing hormones. D-aspartic acid is one. There's not a lot of great research on D-aspartic acid, but it can improve testosterone levels in some folks. But for the most part, supplements, they're not FDA regulated. So a lot of people, we don't know what's in them. In fact, research has shown that when you actually look at the components of some of these supplements, it's not actually what they put on the labels. So they can be dangerous, and we recommend against using supplements when it comes to those that market as performance enhancers or testosterone boosters. Dennis, I'm going to have you tune in here for a second, because you've tried a supplement in the past. So what was your experience with that?
Yes, and you actually just mentioned it, Nugenics. I tried that off and on for a couple different years when I was first, diagnosed with low testosterone, or testosterone deficiency, as you call it. And it did nothing for me. And after even researching into it a little bit more in that, and I found out one of the ingredients in it was beaver castor. No, I decided I was not going to take it anymore after that. But yeah, the testosterone deficiency, as you know, was diagnosed about 10, 12 years ago. And it was actually by chance with my new endocrinologist during one of the discussions I was having with her on my type 2 diabetes, were those different things you had highlighted, the possible injury to the testicles, being overweight, being diabetic, and that. The sleep apnea hadn't come along yet. I hadn't been diagnosed with that, but all those other things played a role in it. And my total testosterone at that time, at the beginning of all this, was in the 120s. And it had been even measured a couple different times down under 100. So yeah, no, supplements, over-the-counter stuff. I do take vitamins, multiple vitamins, and some other things. And for me, I don't know if it's something in my head that triggers it, but they do work for me. So I stay with those. But anything as far as something to help my testosterone, no, I'm going to stay with the injectables.
Mhm. Awesome. Thank you for sharing, Dennis. All right, so let's get into the various treatment options when it comes to medical intervention. So the first one, we'll talk about exogenous testosterone. So that is giving someone testosterone itself. Now, the important thing to keep in mind when it comes to giving someone testosterone is that the body sees testosterone and says, oh, we're good. We can shut down production. So the brain sees the testosterone that we're giving someone and actually stops or reduces downstream signaling, which is really important to consider for guys who are considering current or future fertility. Look at all the different dosing profiles of available testosterone formulations. Not even this, it's this as well. So if you look at all the different ways that we can administer testosterone, I don't know of too many other therapies where there are so many ways of giving a medication. Now there's an oral medication too that's not on this list. Intranasal, in the cheek, under the tongue, short acting injections, long acting injections, pellets, gels, patches, different types of gels, different types of patches. So you name it, there's a way to administer testosterone in so many different forms. And a lot of people will look at this, both patients and providers, and say, oh my, I don't even know where to begin. So I'm not even going to start, because this can be overwhelming for everyone who looks at a chart like this. And even if you look at the variations in a starting dose, I mean, you could do 50 to 200 milligrams every 7 to 14 days. So providers who may not have expertise in testosterone might look at that and say, where do I even begin? Am I going to hurt this person? Do I start low and go high? Do I start high and go low? So it's a lot of different ways that we complicate this matter simply based on all the different ways that we can administer it. Now, I will say it's great. It's great that we have all these options in terms of cost considerations and what people are interested in terms of longer acting therapies versus shorter acting therapies. But it can be a little bit overwhelming for folks. All right, this is my go-to is intramuscular testosterone injections. And the reason why, in terms of testosterone formulations, why I tend to use injectables for most of my patients is actually for a variety of reasons. One, it's cheap. We teach our patients how to self-administer. Some clinics, they have you come in every week or every 2 weeks to get the injection. And while we can certainly arrange for that, it's pretty inconvenient to do something like that. So most of our patients will learn how to self-inject, usually into the quad muscle, and do that on a regular basis at home. There's no risk for transference. With the gels, if you're around young children, if it's still on your skin, you can actually transfer that gel to a child, which can cause them to have elevated hormone levels. So that would not be good. And then we don't have to worry about absorption. So with testosterone, I know it's going into the body. With the topicals, not every person will actually absorb the medication through their skin. So if you've been on topicals and let's say you haven't noticed any difference in how you feel, it's important to check the testosterone level to see, are you actually absorbing the medication, and does the dose need to go up, or might you need to switch to a different formulation? But something to definitely consider is whether or not you're okay with injections and doing self-injections, because if you're not okay with injections, it doesn't mean that you're a wuss. It just means we'll try a different therapy. Like, that's perfectly acceptable. There is a higher risk of causing an elevated hematocrit. And the elevated hematocrit can cause the thickness of the blood to be too thick and have some issues with that and side effects. So the testosterone injections are going to be the highest risk when it comes to all these different formulations causing an elevated hematocrit level. Now, you saw in that previous slide all the different ways that we can dose it in terms of the wide range of how much we give, but also how often we give the medication. I'm typically dosing it once a week to try to avoid the highs and lows of a roller coaster. Within a couple of days of getting a testosterone injection, it's normal and expected to have testosterone levels that are even above the upper threshold of normal. And then they'll go down. But for people, if you dose it like every 2 weeks, the medication doesn't actually last the 2 weeks. So people are more likely to have the highs and lows. So Dennis, why don't you touch on when you were initially started on testosterone, how often you were taking it and what your experience was with topicals?
So when I was first diagnosed and during those first couple of years, the injection frequency was once a month, and it was 200 milligrams of the testosterone cypionate. And for the first, 7, 8 days after an injection, I was great. I had all the energy level. My libido was great. But then I'd crash. And then for 3 weeks, it was Dennis, the couch potato, eating the corn chips and all the, the junk food and that we've finally gotten rid of a lot of those over the past couple of years. But now I do, after talking with you, I do twice weekly of the 200 milligrams, and my energy levels are now on a consistent level. My libido's on a consistent level. And I'll tell you, for a 60-year-old man, there's times I feel like I am back when I'm 20 years old, and I had all those energy levels.
Awesome. And then can you touch on your experience with topicals?
The topicals, my endocrinologist moved me to that when we talked about the roller coaster effect of the once a month, and I didn't like it. It did nothing for my testosterone levels. She was taking them once a month, my bloods. But besides that, the odor of it, I don't know if it's an alcohol base on it or whatever, but I did not care for it. It actually gave me a headache and that, and I just did not like it.
Yeah, you brought us some really great points. And a lot of people use topicals, so there's nothing wrong with them. There are cost considerations, though. The topical medications can be very expensive for people. And sometimes I'll not use like that 300 as like a strict cutoff. There are some guys that I'll treat between the 300 and the 400 range. So if the insurance is using 300 as their cutoff and they don't cover it, then the topicals can be cost prohibitive. If the insurance company is using the reference range of the lab, which could be 200 to 800, and I'm treating someone with a level of 250, that's where the topicals can also be cost prohibitive. When it comes to the injections, if you pay, cash at like place like Hy-Vee at our Iowa River Landing pharmacy, if you use GoodRx, it's actually very cheap. I want to say it's like $60 for like a 3-month supply. So the injectables are also very cost effective. And then not only do my patients, for the most part, really like the injections, I have a lot of patients who use, like Dennis used to be on the topicals and do really well on the injectables. But looking at online support groups has also been really helpful. I've been in practice for 4 years, but when I look at what people are talking about on like closed Facebook groups, it allows me to get a lot more information rather than seeing, let's say, thousands of patients that might take, a few years to see all those patients. I can see feedback in real time from men all over the world to get a better sense of what types of regimens people like. And for the most part, when you look at those different support group messages, a lot of those men are preferring injectables. Now, Dennis, you're very active on those social media support groups. So what are some of the things that you're seeing in terms of feedback from men in the community?
There's still one of the big fears there, and I know we talked about it just before this, and that was the potential of getting cancer from taking testosterone and that. And, you and I just recently had that same discussion while I was going through the BPH and stuff like that. And you try to explain this to some of these guys and they're nope. You show them the proof and they finally start to realize, and I've been noticing a little bit more of a trend now where other individuals are coming forward too and saying, no, that's just not the case. The other thing is, the twice weekly dosing. Some guys are even taking that to 3 to 4 times a week. I'm feeling great on twice a week right now. And as you and I just recently discussed, I'm going to be switching from the intramuscular injections to a subcutaneous injection. And supposedly, according to the new data out there, this is also supposed to help raise the testosterone levels a little bit. So we'll give it a try.
Yeah, and I think your message,
if it's okay with you.
I think your message there, Dennis, is it's good to pay attention to your body. We don't really encourage
Yes.
the men to pay attention to their bodies, but wanting to feel better and understanding, oh, today I don't feel as well. And how might I change in terms of what I'm doing with my medications or lifestyle so that I can optimize my health? And like feeling well is reason enough to change management. And I think
Very
you're
much
the
so.
epitome of listening to your body and asking questions to see, can I do this? I read this online. What do you think, Doc?
Yes, very much so. And since, well, it's been a year now, and a year ago this time, I weighed 256 pounds. I'm now down under 220, around 215 right now again. And it has helped considerably. It has done wonders for my attitude. As I said before, when you were taking care of Lexi, the sleep apnea I was diagnosed with was about 4 years ago. And it's been a love-hate relationship with that CPAP machine. As a matter of fact, for quite a while there, I was only getting about an hour or two a night of sleep with it. But now, for the past couple of weeks, about a month now, I'm back up to 7, 8 hours a night with it on, and the changes are just phenomenal. What it does to you, just getting that sleep.
Yeah, the sleep apnea component cannot be understated, right? It's so important to
Yeah,
recharge the
it
batteries.
is.
All right, so let's talk about testosterone and fertility preservation. So recovery after testosterone, after stopping exogenous testosterone therapy usually happens within 12 to 15 months, but the person may not recover normal spermatogenesis or ability to have good sperm in their ejaculate. Testosterone therapy does not treat infertility. When guys come in because they have infertility issues and they have low testosterone, the answer is not put that person on testosterone therapy if they're trying to optimize their fertility potential. So that's something really important to keep in mind. And a lot of people don't know that. There was a question about, these men's health clinics, these online clinics. And the reality with a lot of these men's health clinics is they'll put anyone on therapy, and they don't always have the discussion of how they can hurt someone on therapy. They also will go through some of the other medication options. Will say, oh, you're going to be on HCG, Aromatase, and testosterone or Clomid, and you have to be on all of them in order to do this therapy. And they don't actually give you the choice. But in reality, you can have a lot of choices about doses and frequency and what medications you want to be on. A lot of those clinics actually don't give you the choice. But taking testosterone is oftentimes causing infertility. Now, people can still have children on testosterone therapy, but you just have to be aware that that's not going to be the case in everyone. And it's important to consider for those who are using, let's say, androgenic anabolic steroids, let's say earlier on in their life, is that can cause prolonged issues with fertility because not everyone will recover even after stopping. So we're still able to increase testosterone levels in those who are desiring the ability to have a child, but we're going to consider alternative medication therapies rather than giving someone testosterone. So let's talk about what some of those therapies are. And these medications can also, and I oftentimes use them in combination with testosterone for a variety of different reasons. It's important to keep in mind here that testosterone, some of it will get converted to estrogen by this enzyme called aromatase. We have a medication that we can block this enzyme to increase testosterone levels and decrease estrogen levels. So those are aromatase inhibitors. Now, the typical regimen that I would use would be a very low dose of this medication. It's also used in women, but I'm using it oftentimes in a much lower dose than we would use in a female. I'm typically using 0.5, that's a half a tablet, to 1 milligram every week. Now, depending on the dose of testosterone I'm starting someone on, if their baseline estrogen level is at the higher range of normal and I'm putting them on injectable testosterone, I'm probably going to recommend that guy go on a low dose of a once-a-week estrogen blocker to prevent that guy from having high estrogen side effects like breast tenderness, breast swelling, acne, fluid retention. For guys who want to minimize the medications they're on and let's say not be on an estrogen blocker, I would actually start them off at a lower dose of injectable testosterone rather than on a higher dose in hopes of minimizing these other medications. This medication is for those who have elevated estrogen. It is not FDA approved for use in males. So oftentimes, or all the time, we're actually using it off label. Other medications that we'll consider is going to be HCG or human chorionic gonadotropin. And this medication, the body actually sees it like LH. So I can actually give someone this signaling molecule to directly stimulate the testicles to produce testosterone. This medication can be very useful in men who are coming in who want to have a child and preserve fertility. Is if their LH level is low or low normal, it's a signaling problem. So I'm going to give them a signaling molecule like HCG to see if we can not only boost his testosterone, but also improve his semen parameters. And this medication will dose, it's variable. So it's if we're trying to preserve testicular volume, because when we start someone on testosterone, because it's shutting down downstream signaling, the testicles oftentimes shrink up. So for men where that would be bothersome to them, and that could be men of any age, someone could be 80 years old and be bothered by that, and that's fine, then I would put that guy on a once a week estrogen or HCG injection to give some stimulation to the testicles to keep up some function so they don't shrink. Dennis, you are on HCG, and what has your experience been with this medication?
Well, at first, before I had even heard of the HCG and was on the testosterone, yes, the testicles do shrink compared to a raisin. A little bit bigger, but more or less you get the idea. So, and it was more or less vanity for me, like you said. It bothered me that the boys were not there anymore.
Dennis, I'm
So
going to interrupt you real quick. It doesn't make you vain to be concerned about that. That is
thank you.
that is a normal thing to be concerned about, and that it does not make you vain.
Thank you, Doc. So anyways, we do 3 injections a week. What is it, like half a milliliter, something like that, 500 IU per week. And then also the 1 milligram anastrozole when, I'm feeling symptomatic. If I'm feeling, I don't think I've ever noticed any breast tenderness in that. Mine were mostly emotional type symptoms in that. But yeah, it's you really got to pay attention to your body and that as to what's going on. As you know, and I know, I've also had high hematocrit, and by taking care of that, I donate blood every 8 weeks, which seems to keep that on an even keel on that 8 weeks period there. But I'm happy with what's going on right now. Very happy.
Yeah.
So,
and I think you all can appreciate from what Dennis is saying is we can get very nuanced and complicated with these therapies. And some people are like, let's minimize it. I don't want to worry about all these things. And that's fine as well. So I have some patients that are on single agent testosterone injections once a week, and they don't worry about the estrogen blocker. They don't worry about the HCG, and they do just fine. So everyone's a little bit different. It's how we provide personalized care. It is certainly not a one size fits all for anybody when it comes to testosterone. When I think about testosterone evaluation and management, it's really the art of what we get to do as healthcare providers. My low testosterone patients are my happiest patients. I love seeing, most of these guys in follow-up because they're happy people for the most part, which is fun to treat. And then we'll briefly touch on the role of selective estrogen receptor modulators. These medications are like clomiphene or Clomid. And what they do is they block the negative feedback of estrogen up on the brain. And so for the body to be responding to these medications, it should see, okay, we have decreased negative feedback of estrogen. So you should actually ramp up the LH to send more signal to the testicles. I don't use these medications for the typical men that I have on testosterone that I'm treating for low T. These medications play a role in my practice if someone is actively trying to have a child and I want to boost their counts. But otherwise, I haven't seen many patients who actually feel better on this medication. Other people will say different things, but it would not be within my routine practice to do it because people just tend not to feel better. Some men's health clinics, because HCG is actually really hard to get these days, there have been all these national shortages and issues getting, is some of these men's health clinics are saying, well, because we can't get HCG, we'll just throw this person on Clomid. And I don't think that's the right answer either. You don't really need either one of those medications. When it comes to follow-up, it is actually not too complicated either. In general, if I have someone on topical therapy, I will check their testosterone to confirm that they are absorbing the medication. Our guidelines do recommend that anyone who's on testosterone therapy has their testosterone level checked every 6 to 12 months. If my patients feel great on therapy and they don't have any side effects, then I'm typically just checking the estrogen and the hematocrit, and I'm actually rarely checking the testosterone. Some insurance companies will mandate that you check a testosterone every 6 to 12 months. So that's most of the time when I'm checking it, but there aren't any great guidelines in terms of when to check the testosterone. And it's going to vary depending on, are you checking it at its peak, or in the mid cycle, or at the low part of the cycle? So there aren't any great guidelines in terms of when to check it. So I tend not to. For most of the guys that I'm treating for low T, I'm treating how they feel. And my patients can tell me in real time how they're feeling, and then I will change management accordingly. I'll check LH with people who are on SERMs. I check estrogen really whenever I'm checking labs. So that's going to be at 3 months and then yearly. Or if I'm changing the testosterone regimen or the estrogen blocker regimen, then I'll check the estrogen level in about 3 months as well. If anyone's doing fine on therapy, but then calls in and says, look, I've been more moody recently, I've noticed some breast symptoms, I've noticed some fluid retention, the first thing that I check is actually the estrogen level. And oftentimes that's a little bit on the high side, which is causing those bothersome symptoms. I'll check a hematocrit at 3 months and then yearly. And then a PSA in terms of follow-up will be variable, but typically I'm checking that once a year. If we're starting you on testosterone therapy and you're 40 or older, we're also going to check a baseline PSA because the prostate is a hormone dependent organ. And then I'm always asking my patients, if I start them on therapy, if they don't feel better, if I'm not improving their symptoms on therapy within 3 to 6 months, we're going to talk about whether or not they want to stop therapy. I would say the minority of my patients want to get off therapy because even if they're not noticing those game-changing benefits in terms of how they feel, they're usually noticing some improvement in their sex drive, their erections, their mood, their ability to gain muscle when they're working out at the gym, their energy. So usually for a little bit of benefit, a lot of the patients that I treat actually do want to stay on therapy. And there's no stop date. So there's no one that's ever too old to be on testosterone. So I treat men even in their 80s on testosterone therapy. And testosterone is actually really important in the body for so many different reasons, not just the ones that we described. I listed the major benefits here. So testosterone therapy can lead to better erections for those who, let's say, and I don't necessarily put someone on testosterone to treat erectile dysfunction, but when you optimize hormones, men will respond much better to medications like Viagra, Cialis. What I'll see are guys coming in for ED, they tried Viagra, Cialis, nobody checked their testosterone, we checked their testosterone, those medications are no longer working, we put them on testosterone, optimize their hormones, and all of a sudden they're responding great to Viagra, Cialis. My happiest patients are those that I probably have on testosterone and a daily Cialis, to be honest with you. It can improve sex drive. It can improve blood counts. So as Dennis was talking about, it can, as a side effect, it can increase hematocrit. But for some people who run low, their blood counts are low, they're anemic, this side effect can actually be quite beneficial for folks. It can increase bone density. So that's one of the reasons why I wouldn't stop testosterone in someone who's 80 years old, is because that 80-year-old bone density, bone health is going to be so important for that person. So I wouldn't want to just stop the testosterone unless there was a big reason to do so. It can improve lean body mass, improve depressive symptoms. It's not necessarily a treatment for depression, but can improve symptoms. And I'm always hoping that when guys come in, and they're on a bunch of medications for their mental health, and we can help them feel better on testosterone, the hope always is to then minimize medications. Are there other medications we might be able to take you off because you no longer need them? Dennis, we got to wrap this up in like 5 minutes. So in 30 seconds, can you describe what some of the benefits you've noticed are when it comes to testosterone?
Oh, my attitude is so much better than what it was. My energy levels are fantastic anymore. And the same with the libido. As I said, sometimes I feel like I'm 20 years old again. But there was a question there in the questions that somebody asked what the difference was between IM and the sub-Q. Now, this is the needle that I'm currently using. I don't know, let me try and get it focused in here. There we go. That is a 22 gauge 1-inch harpoon. And yes, I can feel that going into my muscle, and I jab that into my thigh. I alternate thighs twice a week. After talking with Dr. Amy, I'm going to go to a sub-Q type needle, which is going to be a little bit smaller in diameter. I think we decided on a 26 gauge and either a 1/2 inch or a 5/8 inch. And then that would go directly into any type of abdominal fat or thigh fat versus jabbing it all the way down and into the muscle and that. And just be sure that either way you're doing it, make sure you've got gauze handy or alcohol pads. Keep everything as sterile as possible. I have already hit, struck oil a couple of times when I'm jabbing that harpoon in, and I didn't know blood could squirt that far out of a leg. I hit the kitchen cabinets from about 5 feet away the one time on a stream, and yeah, the wife come walking in right after that, and Joe, what the heck are you doing? I don't know.
So there are different ways to do the injections. Most of my patients do it IM, but if they were to say, hey, I want to try sub-Q, I would have no problem with that. And in speaking with other people and looking at what people are saying online, and I'll be curious to hear what Dennis thinks. Some people do better with sub-Q, some people do better with IM. And really it's just, trying different things yourself to see what you like better. It can have implications just on bleeding and comfort, but also absorption of the medication. And so for a variety of reasons. And the sub-Q method, there's research to say that it can has fewer side effects when it comes to elevating that hematocrit level. So that can also be an advantage of trying the sub-Q method. When it comes to potential risks, these are the ones listed here: flushing, edema, swelling, breast enlargement, injection site pain, testicular shrinkage, infertility, acne, scalp hair loss. And so raising testosterone levels will then increase DHT levels, which can then cause male pattern baldness. That is a really important thing to consider, is it can cause people to lose some hair on the top of their head. When it comes to some hot topics here, testosterone and prostate cancer are certainly one of those. There's no evidence that links testosterone therapy to the development of prostate cancer. Many men with low testosterone and a history of treated prostate cancer can actually be safely treated with testosterone. I see a lot of guys who have had their prostate removed, who have had radiation, they have undetectable PSAs. There's been a lot of research coming out over the last 5 to 10 years that shows that those guys are at no higher risk of their prostate cancer coming back, even in some of those high risk groups. Special considerations are going to be when that prostate cancer was treated, how far out you are from treatment in terms of comfort. There's not much guidance in terms of like when you can start someone back or start them on testosterone therapy after they're treated for prostate cancer. So that'll depend on who you're seeing, what your pathology was, if you were on, let's say, testosterone before going into surgery, and your comfort level. There's also, guidance right now saying that people who are even on active surveillance because they have low risk prostate cancer, in terms of putting those guys on testosterone. I have a few, and they're people that we see on a routine basis, and we follow their PSAs, and we'll get routine biopsies on them, and they understand, that we're going to keep a close eye on them if we are putting them especially on testosterone. And then when it comes to prior androgen deprivation therapy, the purpose of that therapy to treat prostate cancer is to lower the testosterone. So those who, let's say, are going into ADT treatment who have low testosterone levels to begin with, those guys are going to be less likely to recover their testosterone levels afterwards. There are some guys that we might consider if you're on, let's say, ADT temporarily when you're getting radiation, that maybe once you're far enough out and you're doing well, that if your levels have not responded and gone back to normal, that we might start testosterone. But for guys who are, let's say, on prolonged ADT for high risk disease or are currently on ADT, then it would not be a safe thing to do to put those guys on testosterone therapy. But our understanding of testosterone prostate cancer has really come a 180. We used to think adding testosterone and treating these guys would be adding fuel to the fire. That's actually not the case at all. And actually some research now out of Johns Hopkins is looking at those who have like metastatic prostate cancer and actually giving those guys high doses, really high doses of testosterone. So I think it's going to even look a lot different in the next 5 or so years. But in general, if you've had prostate cancer and it's been treated and your PSA levels have been undetectable, then it's generally considered safe to put you on therapy. When it comes to,
would that be the same for colon cancer too then?
Yeah. So
prostate?
Okay. Yeah. So colon cancer, there's nothing to say that would be, a concern in terms of putting those patients on testosterone. When it comes to testosterone and heart health, another hot topic. So there was information, studies that came out in JAMA, New England Journal of Medicine, really respectable journals a few years ago that said that, you know, these types of medications would increase risk for things like heart attack or stroke. The problem is those studies were actually not well done. And so more and more research is coming out now to say that low testosterone is actually a risk factor for heart disease. We don't know whether starting someone on testosterone therapy increases or decreases that risk of heart disease, but more and more research is coming out that treating low testosterone improves obesity, improves metabolic syndrome parameters, improves blood pressure control and insulin sensitivity. And all those things are markers and impact heart disease. So, you know, more and more research is saying that actually testosterone is important for minimizing cardiovascular disease. And then it's unclear whether testosterone therapy improves cognitive function, measures of diabetes, energy, fatigue, lipids, and quality of life. But I see this every day, all day, is that in some way, shape, or form, a lot of the guys that I treat are improving in one or many of these parameters. Elevated hematocrit is the important thing to keep in mind here. It can increase the thickness of one's blood. When the hematocrit is elevated, people can feel or look really flushed, get headaches, feel crummy, feel sluggish. So there are different ways to minimize this elevated hematocrit. Oftentimes it's because someone has undiagnosed or untreated sleep apnea. So that's like the number one thing I'm looking at is I'm asking, have you been tested for sleep apnea? Let's get you tested, because then that can lower the hematocrit and we can safely treat someone's low testosterone. Lowering the dose of injectables, switching to topical formulations, having someone donate on a regular basis, all of those things can improve the hematocrit levels. So the main points here are that drugs used illegally for performance enhancement are oftentimes the same drugs that we as providers use to increase androgen production. Testing for low testosterone is simple, but the interpretation can be nuanced. And several treatment options exist to boost one's own body's ability to produce testosterone, as well as to supplement your levels. Dennis already provided some tips and tricks there. I have additional content on my website, pearlmanmds.com. These are linked to my YouTube channel, so additional videos talking about all topics related to men's health. And we have upcoming webinars here. You can check me and Dennis out on various social media platforms. And then for the next Tuesday of every month, next one's coming up on May 3rd, and we're talking about male stress urinary incontinence. So that's usually after prostate cancer treatment when a male leaks urine related to stress and activity. So Caitlin, wrap us up. And for the questions that I didn't get to, because those are really great questions, what I'm actually going to do is I'm going to answer those questions and post it on my YouTube. So if you check out my YouTube channel, just search Amy Pearlman. I'll be addressing those questions on my YouTube channel. All right, now I'm done talking.
All right. Well, thank you, Dr. Pearlman and Dennis, for joining us tonight. And thank you for everyone else who joined the webinar tonight. So after we end, you'll be prompted to complete an electronic evaluation for our program this week. And then you'll also receive a follow-up email with links and resources within the next week. Thanks, everyone.